From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to our listeners around the world. I'm Dr. Kristin Walter, Deputy Editor at JAMA. I'm joined today by Dr. Stephen Holt, Associate Professor of Medicine in the program in Addiction Medicine at Yale School of Medicine in New Haven, Connecticut.
Honor and a privilege to be here. Thanks, Dr. Walters.
To start off, can you define alcohol use disorder?
Sure. If you were to look at the DSM-5, the Diagnostic Statistical Manual, there are 11 very specific criteria that define what alcohol use disorder is. But stepping away from those very rote criteria, we can simply state that alcohol use disorder is a pathologic relationship to alcohol that is characterized by a loss of control in terms of drinking, usually the presence of consequences, which can range from physical consequences, social consequences, meeting various role obligations or other types of consequences. And typically it's characterized by the presence of cravings, sort of this insatiable desire to use this substance.
And how common is alcohol use disorder?
It's remarkably common. There's a lot of conversation, of course, in media and in public health sphere talking about opioid use disorder and the terrible epidemic of opioid overdoses that have really gripped the nation for this past 15, 20 years in particular. But compared with the morbidity and mortality associated with alcohol use disorder, really AUD far outstrips the consequences of OUD, opioid use disorder. And it really is one of the most prevalent preventable causes of morbidity and mortality on the planet. So it is something that is certainly not an invisible condition that all of us will see in whatever practice of medicine that we are involved with.
So in addition to behavioral interventions such as motivational interviewing and cognitive behavioral therapy, 3 medications are approved by the U.S. FDA for alcohol use disorder. Those are naltrexone, acamprosate, and disulfiram. What do guidelines recommend as first-line treatment?
So the guidelines have been fairly consistent on this for some time, that if you look at the American Psychiatric Association or the guidelines put out by the PCSS, the Providers Clinical Support System, and other agencies, generally the recommendations are to use naltrexone and acamprosate as first line. One slight nuance is the Department of Veterans Affairs recommends naltrexone and a non-FDA approved medication for alcohol use disorder, topiramate, a well-known anticonvulsant. But otherwise, it's really those 2 or 3 medications that are recommended as first line. And that's also consistent with some international agencies as well, like the NICE guidelines in the United Kingdom and in Europe as well.
So moving on to the medications, let's start with naltrexone. Can you describe its mechanism of action and route of administration?
Sure. So somewhat counterintuitively, naltrexone, which is an opioid antagonist, has been shown to be effective for alcohol use disorder, which may surprise folks at first blush. But while we oftentimes think about the effects on the GABA system and the glutamate systems when folks consume alcohol, alcohol also directly leads to the release of dopamine and the release of endorphins from your pituitary. So it's naltrexone's ability to block those reinforcing effects of those beta endorphins that are released that leads to the reduction in cravings and reduction in those reinforcing properties when people consume alcohol. So that's how naltrexone works. And in terms of administering it, we can either have patients take it once per day by mouth, a 50 milligram dose, or there is a long-acting injectable form that's been around for 20 years or so called Vivitrol, the extended release formulation of naltrexone.
And how effective is naltrexone for alcohol use disorder?
There's been dozens of studies that are well-designed in randomized controlled trials and a couple of meta-analyses which have looked at this with tens of thousands of patients over time. And the data is pretty clear that naltrexone has a modest effect on a number of alcohol-related outcomes, whether it's reducing the amount of alcohol a person consumes, the number of days that somebody drinks to excess, and to a lesser extent impacts on abstinence itself. But in general, whether you use the oral form or the injectable form, there is evidence that naltrexone can decrease alcohol consumption. And sometimes we like to use number needed to treat data when comparing different medications. And for naltrexone, the number needed to treat to achieve one of these important outcomes in the alcohol literature is about 11 for naltrexone.
And what are potential adverse effects of naltrexone, and are there certain patients who should not be treated with this medication?
The most common side effects that we see with either form of naltrexone are nausea. Certainly, sometimes we can see headache, and then specifically with the injectable form, you can certainly see an injection site reaction. This is a 4 milliliter dose that's injected into the gluteus muscle. So it's a pretty large dose, and so perhaps unsurprisingly, people can experience some discomfort when receiving it. But otherwise, nausea and headache are relatively self-limited side effects that people may experience. And really, the only significant contraindication would be folks who are on opioids for some other reason. We certainly can't use naltrexone for a person who's stably on methadone or buprenorphine or any other full or partial opioid agonists.
The second medication your article discusses is acamprosate. Can you describe this drug's mechanism of action and how is it prescribed?
Sure. We know that acamprosate impacts or stabilizes the imbalance that comes with prolonged alcohol use to the GABA and glutamate neurotransmitter systems. It's not 100% clear exactly how acamprosate does that, but that is believed to be the mechanism or the site at which acamprosate is having its effect. And ultimately, it's decreasing cravings that patients experience so that they are less likely to consume alcohol or consume less of it.
And how effective is it for alcohol use disorder?
Pretty similar to acamprosate, looking at large meta-analyses of double-blinded randomized controlled trials. We have dozens of studies, tens of thousands of patients looking at a host of different alcohol-related outcomes. And by perhaps coincidence, the number needed to treat for acamprosate is also 11, which was the same number needed to treat that I reported for naltrexone. So overall, pretty comparable efficacy and safety data for these two medications.
And what are potential adverse effects of acamprosate, and are there any contraindications to its use?
Acamprosate is pretty well tolerated. The most common side effect that we see in about maybe 5 to 10% of patients is just diarrhea, which can also be self-limited. So otherwise pretty well tolerated. And the benefit of acamprosate is that it is metabolized by the kidney instead of the liver. So it's very safe in folks with even advanced liver disease. It's really only those folks who have very advanced kidney disease that we have to exercise caution when prescribing it. So folks with a GFR between 30 and 50, you would cut the dose in half. And for folks with a GFR less than 30, you really can't prescribe acamprosate.
And the third drug that your article discusses is disulfiram, which was FDA approved for alcohol use disorder in 1951. Can you describe the mechanism of action of disulfiram?
Definitely not a new kid on the block. Honestly, all these medications we've talked about have been around for 20 years or so, but this one's uniquely been around for almost 80 years, so an extensive body of literature looking at it. The mechanism is fairly straightforward. It is interfering with one of the important steps in the metabolism of alcohol. So when one consumes alcohol, it's converted in the liver to acetaldehyde. And then acetaldehyde is converted via another enzyme, aldehyde dehydrogenase, into acetic acid, which is a completely benign substance that comes out in the urine. But by blocking that enzyme, the aldehyde dehydrogenase enzyme, you're leading to the accumulation of acetaldehyde. And this is a toxic substance. It's a really unpleasant substance. It's believed to be the driver for most of the symptoms that one associates with a hangover. It's actually the primary carcinogen that causes so many untoward consequences in folks who drink heavily. So by leading to the accumulation of acetaldehyde, folks experience a very unpleasant so-called disulfiram ethanol reaction within potentially minutes of consuming alcohol.
And your article discusses that disulfiram has been considered a second-line medication for alcohol use disorder, but that recent new analyses of prior data have shown greater efficacy for supervised disulfiram. Can you discuss these findings?
Yeah, this is fascinating stuff, and it's evolved just over the 20 years of my career and working as an addiction medicine specialist. I was taught, as many folks were taught, that disulfiram is second line. It's really only for a very small group of patients. The data is not great, et cetera, et cetera. And it was actually in 2014 when Marilyn Skinner and some of her colleagues, Colin Brewer and some other folks that did some research on this, really looked at the mechanism of action a little bit closer, and in particular looked at the best way to study this medication, which has such a unique mechanism of action. The simplest way to say it is, if I was to put together a study where I offered you a red pill or a blue pill, and one of those pills will make you violently ill if you drink alcohol, it's not the red pill or the blue pill that actually is doing anything in its own right to change your cravings. It's when you drink alcohol. So if I was to do this double-blinded randomized controlled trial, you as a subject are not going to know whether you can or can't drink alcohol because you don't know if the red pill or the blue pill is the active agent. And so the problem is that you're going to significantly dilute the potential deterrent effects of disulfiram in a double-blinded randomized controlled trial. So many prior studies and meta-analyses looked at double-blinded randomized controlled trials, found very limited efficacy for disulfiram. In contrast, when we filter out or exclude those double-blinded RCTs and focus instead on open-labeled RCTs, you actually see significant efficacy for disulfiram, even when you have open-labeled RCTs comparing disulfiram with the other medications I mentioned, acamprosate and naltrexone. So bottom line is that with more rigorous and appropriate methodologies looking at the efficacy of disulfiram, it looks like actually this medication may be quite effective. And a number of folks have argued that it really should be one of the first-line agents, certainly for alcohol use disorder.
And aside from the negative physiologic effects of consuming alcohol with disulfiram, what are some other potential adverse effects of this drug, and are there contraindications to its use?
Sure. So disulfiram side effects generally are mild or absent for most folks who are just taking disulfiram and don't consume alcohol. So some folks report fatigue. I've had folks report nausea, certainly. And very rarely, severe hepatotoxicity can occur when taking disulfiram. But mostly it's the interaction with alcohol that people worry about. And so if somebody consumes alcohol while taking disulfiram, it can cause a pretty severe reaction with all those symptoms of a hangover, nausea, vomiting, headache, tremulousness. And if somebody has advanced cardiac disease or has other high seizure risk or those sorts of things, even just the electrolyte disturbances that could accompany the protracted nausea and vomiting really make this medication not great for such folks. So that sort of dovetails with talking about contraindications. So I would not prescribe this to a patient with well-documented severe or unstable coronary artery disease, history or recent episodes of seizures. It should not be used in folks with very advanced liver disease. I'm talking like Child-Pugh class B or C cirrhosis. You could prescribe it in someone with class A cirrhosis with appropriate monitoring just to mitigate that risk of hepatotoxicity.
And earlier, you mentioned that topiramate is not FDA approved for alcohol use disorder, but is sometimes used to treat it. Can you describe this drug's mechanism of action and how is it prescribed?
Sure. Topiramate, similar to acamprosate, seems to modulate the GABA and glutamate neurotransmitter systems in ways that I have to say is, again, not entirely clear. And the efficacy data for it is also pretty strong. There was a meta-analysis in 2023 that looked at 8 double-blinded RCTs, and they found that there was a statistically significant reduction in the number of drinking days and the average number of drinks per day. So this medication does have good efficacy for it. The lack of FDA approval should not be a significant demerit in terms of us looking at it.
And can you describe some potential adverse effects of this drug, and are there contraindications?
Yes, this is where topiramate gets into a little bit of trouble insofar as it does have a number of side effects that have been associated with it that sometimes lead patients to discontinue it, and those include clouded sensorium, some fatigue, alterations in taste and other paresthesias which can occur. And that's particularly the case as you start to go up on the dose to some of the target dosing 100 to 150 milligrams twice a day. And in order to reduce those risks of those side effects, we tend to go up really slowly on topiramate over time. But that in its own right is problematic because it can take 8 weeks to get to target dosing with topiramate, which can just be challenging to work with patients over that long period of time.
Once a decision has been made about which medication to prescribe, what should clinicians know about how long they should continue these medications after treatment goals have been achieved? And I guess it depends on your treatment goal of abstinence or reduced alcohol intake.
We think of alcohol use disorder, like all substance use disorders, as chronic, relapsing, remitting diseases. And they're not something you just treat over the span of a few weeks and you have cured. And just because the patient's been abstinent for 30 days doesn't mean that they're magically no longer at risk of returning to use. So we recommend at least 6 to 12 months of pharmacotherapy for patients with AUD. If a person has not yet achieved their goal, but maybe they've partially achieved their goal, there's no reason to discontinue these medications indefinitely. If naltrexone helps a patient to decrease to safer consumption levels, then why stop it any more than you would stop an SSRI if it's clear that it's helping a patient and taking it away makes their symptoms return.
And your article also mentions that initiating medications for alcohol use disorder in the hospital may be helpful for patients who have alcohol-related complications and are hospitalized for that reason. Can you discuss this further?
Yeah, this is so important. And every internal medicine resident or trainee at some point invariably has cared for folks in the hospital with alcohol use disorder coming in with alcohol withdrawal or intoxication or some other complication therein. And yet the rate of prescribing medications for alcohol use disorder at the time of discharge remains fantastically low if you look at discharge data on a national scale in different hospital systems. It's suggested that as few as 2.5% of patients with alcohol use disorder end up getting pharmacotherapy. So you've got a, quote, captive audience, end quote, when a patient has been admitted with alcohol use disorder. They're probably particularly motivated to initiate treatment for alcohol use disorder because they're in the hospital because of some complication of their drinking. And so a message that is really being promoted by the addiction medicine community is to encourage all of us who take care of inpatients on whatever service you may be on to recommend MAUD, medications for alcohol use disorder, to all patients who are admitted with an alcohol-related complication. And there's evidence to support that can decrease all-cause mortality and hospital readmissions when we do initiate pharmacotherapy for inpatients.
And you just mentioned that only 2.5% of U.S. individuals with alcohol use disorder are prescribed pharmacotherapy despite its efficacy. What are some potential reasons for this gap in treatment?
There's many contributors to that. Certainly, again, I was trained 2004 to 2007, and learning about the efficacy and how to use these medications was not a strong part of my training. And that was, if you look at the ACGME's guidelines for internal medicine training, learning about addiction was not part of the criteria, was not part of the requirements. So it's really only been as recently as the past 5 years that the ACGME has required training on treatments for substance use disorder. So part of it is a huge training gap that affects a few generations of clinicians. And then other issues are people have an overabundance of concern about using these medications in folks who have liver disease. And so we're a little bit too cautious about prescribing things like naltrexone or disulfiram, or even acamprosate for that matter, to folks who have liver disease, even though the literature tells us that these medications are safe and in fact really can reduce complication rates down the road.
Before closing, is there anything we didn't discuss in this podcast that you'd like to mention?
My only comment would be for any folks who are involved in creating pathways for inpatients or even in the outpatient setting, we really have to look at creating pathways and quality measures that look at the prescribing of these medications as self-evident. There's so many different conditions that have these pathways and smart pathways in hospital settings where if somebody comes in with X, they should automatically be prompted to do Y. And that really hasn't yet been the case for alcohol use disorder pharmacotherapy, and it should be.
Thank you so much for sharing your thoughts with us about this interesting and important topic. I'm Dr. Kristin Walter, and I've been speaking with Dr. Stephen Holt from the program in addiction medicine at Yale School of Medicine in New Haven, Connecticut. Thank you again for joining us. You can find a link to this JAMA review article we discussed in this episode's description. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.